Hi, I'm Raj, and today I'll be presenting our paper, Coarse Race Data Conceals Disparities in Clinical Risk Score Performance. This is joint work with several others, including my co-first author, Divya. So many recent papers have shown that clinical algorithms perform differently for different race groups. For example, on the right, the x-axis is plotting performance of a risk score. In this case, the score predicts which patients in the ER require hospital admission, and as you can see, the risk score seems to perform better for some groups than others. Many past fairness audit studies do something like this plot, in which patient races are coded very coarsely into a few of these broad census-recognized race groups. But in this paper, we ask if these coarse groups really tell the whole story. That is, we go one level deeper and look at more granular race groups to ask whether there are further disparities within the coarse groups which may have been missed by past work. As an example, consider the patients who are coarsely grouped as Asian. Within this group, some patients identify as Chinese, some as Indian, etc. In total, across the 4 commonly studied coarse races, we look at 26 granular race or country of origin groups, which you can see on the right. Now, if we actually fill in the plot on the right with all of the granular metrics, we see that there is indeed a large amount of performance variation within the coarse categories. For example, comparing to the group average for Asian, the risk score performs better for Southeast Asian patients and worse for Korean patients. On the whole, there are many granular disparities which we would have completely missed by only evaluating on the coarse groups. And so to reiterate, the vast majority of past fairness audits only use coarse race groups. And if the setting there is anything like the ones we study here, these analyses might have missed a lot of demographic variation that we should probably be looking at more closely. I think our results have important implications for how we think about fairness in clinical machine learning in general. For example, even if you demonstrate that there are minimal disparities at a coarse level, there might be a lot of equally important subvariation that you're not seeing at all. This idea definitely relates to recent calls for intersectionality in the study of disparities. And concretely, we would say that it's critical to include granular races in clinical datasets and also audit along granular race when building clinical prediction tools. This style of analysis would allow for a better characterization and understanding of both existing health disparities and disparities which may be created by deploying a risk score. In the paper, we show a lot more experiments to verify the robustness of our results, and I look forward to talking more about these details. Thank you.